or be that thalassemia. And bone marrow transplant is actually, at this moment in time, the only curative regime available for patients. And traditionally, we've always used sibling-matched bone marrow transplants for people with thalassemia, and that has changed recently with the advent of things such as gene therapy. Now, the path to innovative therapies like gene therapy is a very, very long pathway. And what you can see here is the amount of time it takes for a drug to be looked at in preclinical studies to a drug actually moving into the therapeutic arena. Many, many, many drugs start off in preclinical and then fall at the first or the second hurdle. And we've seen this in recent times as well. And actually, when drugs get into the market, there is again a potential for the drugs to be withdrawn, as we've recently experienced. And this is just a simple schema of the path to gene therapy for patients with sickle cell disease and thalassemia. And you can see that this is over decades. So there are a whole bunch of novel therapeutic drugs which are being investigated or have been investigated in patients living with red cell disorders. So what you can see here is drugs such as luspatercept, which work directly on the erythropoietic pathway. You've got the iron hemostasis regulating medications such as bitopertin and VITS or Vamifort. And then you've got newer drugs which are working on the endothelial axis, such as the R-Adams 13. You've got GBT voxelotor, which is working directly on the hemoglobin and improving that in patients with sickle cell disease. And then you've got drugs such as the pyruvate kinase activators, which are being trialed both in sickle cell disease and thalassemia, as well as pyruvate kinase deficiency, to help improve the patient's hemoglobins. So I'm going to talk about transplantation because this has been around the longest, and I'm going to focus on new advances, not on standard of care, which is straightforward matched sibling transplant in patients with thalassemia. So in the sickle cell population, this study was really very pivotal because it basically looked at haploidentical bone marrow transplantation in patients with sickle cell disease, which was a hitherto sort of unconsidered therapeutic intervention. And what's very interesting with this study is they took patients who had really complex disease with multiple comorbidities. And what you can see here is that the majority of the patients had had very frequent vaso-occlusive events. Many of them had kidney disease, acute chest syndrome, and other complications, including pulmonary hypertension, which made them a bad transplant cohort risk, essentially, for a matched related donor transplant. But this was a haploidentical transplant using low-intensity conditioning. And what you can see here is that a year post-transplant, there was a significant improvement in patients' cardiac BNP levels and in their lung function tests, suggesting that the patients were doing extremely well post-transplant. So this then prompted a large Vanderbilt Global Haploidentical Collaborative Group, of which my colleague, Professor Josu de la Fuente, is one of the leads, and he's very kindly lent me the slides that I'm presenting next to you. So in this particular cohort study, they've really explored the use of haploidentical transplant in patients with sickle cell disease, both adults and children, and they've used low-intensity conditioning using thymoglobulin, thiatepa, fludarabine, and cyclophosphamide conditioning as GVHD prophylaxis, including post-transplant cyclophosphamide, MMF, and sirolimus. They had a total of 80 patients from 7 different sites. 45% of these patients were male, and a wide variety of donors. So there were siblings, parents, daughters, cousins, a whole range of different family members, and 83% of the haploidentical donors were actually sickle cell trait. Graft failure was seen in 12% of patients. All of these patients were below the age of 18. Engrafted participants were off immunosuppression 1 year after the transplant, and the incidence of grade 3 to 4 GVHD was only 8.8% in that population. So really well managed graft versus host disease. Median follow-up was 1.4 years, and a survival curve showing the under 18s, comparing them to the above 18s, basically showed a very comparable survival outcome. And this data was presented at ASH in 2023. And if you look at the contemporary cohort of patients with sickle cell disease, the death incidence in comparison to the general population. In patients aged 18 to 23, death incidence is 2.36% per 100 patient years. In patients above the age of 36, it's 4.72. And following bone marrow transplant, the death incidence is brought right back down to a comparable level to the 18 to 36 age group. Post-transplant and pre-transplant conditioning actually abolishes the risk of graft versus host disease and graft rejection. And this is extremely important now because we can show that this is effective in patients below the age of 18. Again, with regards gene therapy, Professor Justo de la Fuentes kindly lent me the most updated slides on Beticel, which I'm going to be presenting here. So gene therapy is essentially a bone marrow transplant, but it's an autologous bone marrow transplant. The process is the same whether you're using a lentiglobin virus or whether you're using CRISPR-Cas9 strategy. It starts off with a hematopoietic stem cell collection. The cells are then sent off to a laboratory for modification. And then once the modification is appropriately managed, patients receive busulfan, myeloablative conditioning, infusion of the modified stem cells, and then you wait for engraftment. In the Beticel study, lentiglobin virus was used and cells were transfected and they produced a hemoglobin, which is a T87QA. And this is a hemoglobin A, and this is actually measurable on HPLC. Now, there were 3 different cohorts because the initial cohort had a low level of transfection as the technology was being developed. And in the final cohort, the modification and manufacturing processes had improved so much that the viral transcription was extremely good, and patients got a very high vector copy number with a really good transplant outcome. What you can see here in the sickle cell patients is the number of VOC events occurring prior to transplant and the absence of VOC events occurring post-transplant. So extremely good from a point of view of actually stopping transplant, stopping VOCs post-transplant. In the thalassemia patients, these are the 3 cohorts, and you can see the ages below 12, 12 to 18, and 18 and above. And these are the transfusion episodes that patients were having. And this is the transfusion independence that you can see for patients. So with the Beticel, what you can see is that the patients who received the best vector copy numbers had a really good response with improvement in their hemoglobins ranging from about 12 to 13 grams per liter per deciliter, whereas the patients who had lower vector copy numbers continued to require blood transfusion post-transplant. CRISPR-Cas9 gene editing is basically editing the gene of the stem cell using CRISPR-Cas9 technology to allow the activation of BCL11, which increases the hemoglobin F production. As I described, the process is exactly the same. It's a stem cell harvest. The stem cells go to the laboratory for modification. Once they're adequately modified, then the patient undergoes busulfan conditioning, followed by infusion of the therapeutic product and waiting for engraftment. This is the results from the CRISPR-Cas9 gene therapy clinical trial, and you can see in the thalassemia patients, regular transfusions pre-transplant and then post-transplant, the absence of transfusions in the vast majority of patients. 3 patients didn't actually achieve transfusion independence. One had a reduction in the annualized transfusion volume of about 83%. The other 2 patients have now been transfusion-free for about between 7 months and 4 months post-transplant. What we know is that you get a pancellular distribution of hemoglobin F, and post-transplant, the majority of the patients have had a very significant improvement in their hemoglobin levels. And this is regardless of what their underlying genotype was. In the sickle cell patients, again, very similar. These are the VOC events pre-transplant, and these are the VOC events post-transplant. One patient, this patient got a VOC event with a drop in their hemoglobin following a parvovirus infection. But they have now become VOC event-free again. And this is the hemoglobin F production that you can see in patients after exa-cel therapy. The transplant complications are very similar to what you would see with a standard busulfan conditioning transplant. There is a slight delay in engraftment of platelets, but nothing much more than that. One of the patients had 3 serious adverse events related to exa-cel, which was hemophagocytosis, acute respiratory distress syndrome, and 1 SAE of an idiopathic pneumonia syndrome, which was thought to be due to exa-cel and busulfan. Another patient had delayed engraftment of neutrophils because, again, thought to be due to busulfan and exa-cel. And none of the patients with sickle cell disease have had any serious adverse events with the conditioning. So gene therapy trials are now proactively ongoing globally, both in the US and in China. And I'm very hopeful that gene therapy will become available globally for patients at a rate at which they can afford. So existing therapeutic agents and repurposing of existing therapeutic agents are the next topic of discussion. So we have luspatercept, which is available. This is an activin receptor ligand trap, which works to inhibit aberrant SMAD2/3 signaling and enhances late-stage erythropoiesis. Luspatercept has been extensively investigated as part of the BELIEVE and the BEYOND clinical trials. This is the schema for the BELIEVE clinical trial, where luspatercept was randomized 2-to-1 with placebo in patients who were transfusion dependent, requiring less than 24 units of blood, less than 20 units of blood over a 24-week period. Patients are now in an open label extended study period. And the drug is obviously available in many parts of the world. BELIEVE trial basically had 224 patients who were randomized to luspatercept, and 21% achieved transfusion reduction of more than 33% in comparison to their baseline transfusion burden between weeks 13 and 24. This was a predefined fixed window period for assessment of response. However, if you look at any 12-week rolling period, a significantly more number of patients had a response. About 50% of patients had a response in any 12-week period rather than the predefined period. So according to the trial, the data for the responders is actually the people with a response between weeks 13 and 24. even though many more people responded. So if you look at the responders here, you can see the non-responders 73% and the responders here with the 33% reduction. But then if you look here at the serum ferritin responses, you can see that in all of the patients, both the responders and the non-responders, there was a reduction in the serum ferritin because many more patients did respond. So again, here, if you look at the cumulative number of red cell transfusion units by the level of by the level from the baseline, what you can see in the responders is that if they had a low baseline transfusion burden, they had a significant response with their transfusion burden. And the mean number of units of blood also improved in those patients. But the patients with the higher transfusion burden, there was no significant difference in that population of patients. So the Beyond clinical trial actually looks at the non-transfusion dependent patients. And again, it was a 2-to-1 randomization of luspatercept to placebo. Patients were given 1 milligram per kilogram subcut every 3 weeks, which was then increased to 1.25 milligrams per kilogram if there was a lack of response. 145 patients were randomized based on the hemoglobin and the fatigue scores that they reported, and 89 patients completed 48 weeks worth of treatment. And what you can see here is that there was a significant improvement in comparison to the baseline hemoglobin between the placebo cohort and the treatment cohort. So patients, by and large, had a good response, and 77% of patients met the primary endpoint, which was an improvement in hemoglobin of at least 1 gram over a continuous 12-week period. But in particular, the week 13 to 24 fixed time point period, that was the primary endpoint, and patients responded very well to that. Main side effects with luspatercept are bone pain. A lot of patients complain of bone pain when they take the luspatercept. It's an incidence of about 36%. They can also complain of muscle pain, but otherwise the medication is really pretty well tolerated by the vast majority of patients. Repurposing of existing drugs, I think, is really important, and thalidomide has been extensively investigated in India, China, and a number of other countries. And thalidomide mechanism of action across a number of studies have shown that it might enhance erythroid transcription factors such as GATA1, binding factors such as TNF-alpha. This results in an increase in the production of intracellular reactive oxygen species and increased production of ROS-mediated P32 MAPK signaling, and histone 4 acetylation induces gamma globin gene expression. Pomalidomide, which is a second, third generation agent in the thalidomide group, is a potent hemoglobin F inducer with less teratogenicity risk, but it hasn't been trialed in thalassemia patients as far as I'm aware at the moment. So one of the first studies that was published was by Yang et al. It looked at 71 patients with a treatment duration with thalidomide of over 3 months. And the inclusion criteria were clinical or a genetic diagnosis of beta thalassemia requiring blood transfusions, but unable to afford regular blood transfusions or iron chelation therapy. And they took patients between the ages of 14 and 65 and an ECOG physical score of 0 to 2, and patients with a history of renal, liver, cardiac, or pulmonary defects were excluded, as well as those patients who'd had thrombotic episodes. This is the results from the trial, and what you can see is really significant improvement in the hemoglobin pre-transplant versus post-transplant in the non-transfusion, pre-thalidomide and post-thalidomide in the non-transfusion dependent group, so going from 7 to 10. And if you look at the transfusion-dependent group, the hemoglobin goes from 5.6 to 9.1. This is total disease modification from a thalidomide perspective in the most severe cohort of patients, which is the TDTs, but also very significant in the non-transfusion-dependent groups. The other thing you see actually in this is an increase in the serum ferritin, which is thought to be due to mobilization of iron to improve the erythropoietic drive. So the ferritin actually goes up in patients in the absence of those patients needing blood transfusion. This study published by Jane et al. Looked at HBe beta thalassemia, and this was published in 2021. It's a very small study looking at 45 patients and just looking at thalidomide with folic acid. And the 12-month follow-up was basically to see an improvement in the hemoglobin levels and in the hemoglobin F levels. The results of the study were really pretty good. There was a 100% responder rate in group 1, which is thalidomide and folic acid. And a 66% major responder rate in patients who were in groups 2 and 40% responder rate in group 3. So a better response with thalidomide and folic acid in comparison to hydroxyurea and folic acid. Both hydroxyurea and thalidomide had improvements in hemoglobin, but more significant in the thalidomide group. And transfusion reduction was significantly better in group 1 in comparison to the hydroxyurea group. So 100% transfusion reduction in group 1 and 34% reduction in transfusion in group 2. No serious adverse events were reported in the patients in this study. And so Louis et al. Has undertaken a meta-analysis of thalidomide monotherapy in patients. And this is the inclusion and exclusion criteria for the studies. And a total of 12 studies were included in the meta-analysis. And you can see that the meta-analysis studies are across a broad range of countries, all in Southeast Asia or the Far East. And an overall response rate was defined as a more than 50% reduction in transfusion requirement or an increase in hemoglobin of more than 1 gram in transfusion-dependent thalassemia patients after thalidomide therapy. For non-transfusion-dependent patients, it was an increase in hemoglobin of 1 gram, and a complete response rate was defined as a complete cessation of regular blood transfusions. What you can see here is that 7 studies had an overall response rate in non-transfusion dependent thalassemia of 91%. So a huge number of patients had at least a 1 gram rise in their hemoglobins. And in 8 studies, an overall response rate in TDT was 83%. So again, a very significant number of patients benefiting from thalidomide therapy. Now, the really important thing, in my opinion, is actually the complete response rate in thalassemia patients. And 9 studies in TDT showed that there was a 52% complete response rate in patients with thalassemia. So these patients became transfusion-free on thalidomide therapy. And the improvement across 8 of these studies was of about 1.6 grams of hemoglobin improvement across all of these studies in these patients. Safety, we're obviously always worried about using thalidomide in patients. 30% of patients actually did get side effects, but the majority of these were mild and common side effects, including sleepiness, constipation, a high ALT, and in some patients, a rash. Only 3 patients developed neurotoxicity and/or a headache, and 1 patient had a central venous thrombus, and 1 patient had a seizure. There's another drug that is being investigated now. This is early data published in 2002. It's being done as a clinical trial looking at sirolimus HbF induction. And sirolimus has been shown to be a strong inducer of HbF in vitro and in vivo in animal models. and in some patients affected by sickle cell disease who were receiving sirolimus following transplantation of kidneys usually. So the study basically selected patients, and this was at time point 1. They then looked at ex vivo treatment with sirolimus. They assessed the patient's genotype, and they measured patients' clinical parameters. They then recruited patients into the study and measured sirolimus and biochemical parameters and gamma globin production and erythroid progenitor cell fetal hemoglobin levels at fixed time points at V3, 5, 6, 8, and 11, and V8 as well, where they looked at fetal hemoglobin levels in peripheral blood. The results of this study are really very interesting. So what you can see here in the patients is that patients get an increase in the hemoglobin F production. This is variable in different patients, but generally an increase in the majority of the 8 patients that were in the study. There is a significant reduction in markers of ineffective erythropoiesis and hemolysis, with a reduction in bilirubin and a reduction in the excess of alpha globin chains that are measured in patients, as well as soluble transferrin receptors. And they also looked at the transfusion demand index in patients, which is calculated by dividing the red cell consumption by the average pre-transfusion hemoglobin. And this was significantly improved in patients as well, so supporting a reduction in the transfusion demand for these patients. I'm now going to talk about new investigational drugs. There's a whole bunch of new investigational drugs that are being looked at. These drugs are predominantly focused on iron regulation and iron restriction, looking at hepcidin regulators, ferroportin inhibition, ERFI inhibition, and a range of these drugs. These are all very, very early studies. There is a drug called vamifeport, which is no longer being investigated in thalassemia, but the study has been reopened in patients with sickle cell disease. The vamifeport was stopped because it didn't show an improvement in ferritin in patients. Its mechanism of action is to diminish intravascular hemolysis and inflammation in a mouse model of sickle cell disease, and hence the sickle cell work is now proceeding. And finally, mitapivat is, I think, a very promising therapeutic currently being investigated. It's a pyruvate kinase activator and works on the glycolysis pathway. It's been investigated in thalassemia patients, both in the ENERGIZE and the ENERGIZE-T studies. ENERGIZE is looking at non-transfusion dependent thalassemia. ENERGIZE-T is looking at transfusion-dependent thalassemia. And it's a 2-to-1 randomization between 100 milligrams twice daily of mitapivat compared to placebo. And patients are now moving into open label extensions with these studies. So in the non-transfusion dependent thalassemia patients, you could see that the improvement in hemoglobin had no relationship at all to any of these key parameters, including the patient's underlying genotype. And they looked at alpha and beta thalassemia non-transfusion dependent patients. Significant improvement in hemoglobin in patients on mitapivat. And what you can see here is a lot of patients with alpha thalassemia had a good response with the medication. The FACIT fatigue score is a really important score, looking at fatigue index in patients with non-transfusion dependent thalassemia. And what you can see here is that there was a significant improvement in the FACIT fatigue score for patients on mitapivat, the vast majority of patients on mitapivat. The ENERGIZE-T clinical trial is looking at the thalassemia transfusion-dependent population, and the response criteria is a greater than 50% reduction in transfused red cells, or more than 2 units of red cells being reduced over a consecutive 12-week period. And what you can see here is a significant improvement in the transfusion burden in the patients who are receiving mitapivat as part of this study. The other efficacy endpoints were also met. Not just, as you remember when I was talking about luspatercept in the fixed time window, but in any 12-week or 20-week rolling, 24-week rolling period in mitapivat, the endpoints were met with a reduction in transfusion burden. Medication has been well tolerated in patients with no real significant adverse events, apart from the headache symptoms that a lot of patients get on mitapivat. In sickle cell disease, there's two mechanisms of action here. So not just the increase in the ATP, but also a reduction in the 2,3-DPG stabilizes the sickled red cells and reduces the impact of sickle cell disease. This has been studied in the Rise Up clinical trial, which has looked at two doses, 50 milligrams BID and 100 milligrams BID. And these patients are now in the long-term follow-up study. The secondary endpoints were a reduction in VOC events, and the data from the Rise Up study shows a significant improvement in patients' hemoglobin levels. As you can see here, in both of the doses, the 50 and the 100 milligrams BID dose, in comparison to placebo. The other key thing is that the VOC events have followed a trend for reduction in patients receiving mitapivat. We obviously need the phase 3 long-term cohort follow-up data to really be sure of where we are with regards to this. So in conclusion, I think there have been real challenges in developing disease-modifying therapy for both thalassemia and for sickle cell disease. The lack of luspatercept availability in many parts of the world, in particular the UK, and the removal of crizanlizumab and voxelotor are concerning because these drugs have gone through quite long workups as part of clinical trials, and then after they've been approved, they've been withdrawn for a variety of reasons. Mitapivat is eagerly awaited, and the data certainly looks really promising, but we must maintain a degree of caution when we're talking to our patients about new drugs because of our experience with crizanlizumab and voxelotor. Because it is heartbreaking for many patients to be on a drug, have a response, and then have it withdrawn. Promising treatments, I think, are haploidentical transplant, gene therapy across the board for sickle and thal, and the use of thalidomide and hydroxyurea, and hopefully in the future, potentially other anti-angiogenesis agents such as pomalidomide. And also potentially sirolimus may be future therapeutics if they move beyond the current usage criteria. So I just want to say thank you very much for asking me to talk. I hope the lecture has been useful. I'm happy to answer any questions.
Thank you. Thank you, Dr. Farooq Shah, for a wonderful lecture. And you already joined now. And thank you so much, ma'am, for first of all providing the video first. Though your flight was rescheduled, we know and we understand. And now I request all our Indian colleagues to please put the raise hand sign so that we can start our question answer session with Dr. Farooq Shah. Just, ma'am, to keep the ball rolling regarding the thalidomide plus folic acid, what you had mentioned regarding the study going on. What is the dose of thalidomide in these patients?
It's actually quite a low dose, 10 milligrams, with a small dose escalation. But generally, it's actually quite a low dose, and patients are getting good responses with that. I mean, the problem is that we can't use it in the UK because it's not under regulatory approval indication for that. And this is why the clinical studies that are being done in India, in China, are just so important. I really do think that I really do think that these drugs need to be repurposed. They're providing much better responses than luspatercept. They've been around for a very, very long time, but we need pharmaceutical companies to really, a bit like what's happened with sirolimus, you need the pharmaceutical company to put in a submission for a new indication. And then once you've got the new indication, show the clinical trial data and then get it approved through regulatory authorities. We absolutely have to follow that process. So I would, strongly encourage my Indian colleagues to grab the bull by the horns and get on with making the drug available worldwide, and even to look at the next generation of anti-angiogenesis agents, and to think about using them, such as Velcade or potentially pomalidomide. But Velcade certainly is available in India. It's cheaper. So we should be thinking about that. I might have used the wrong brand name.
Dr. Shah.
Sorry. Yeah. Yes, ma'am. Please go ahead.
Yeah. Thanks, Dr. Amit. Dr. Shah, nice lecture. I joined a little later though. What I want to ask you is this: yes, thalidomide, but have we looked at the long-term toxicity of carcinogenesis with thalidomide? Are we okay with that data? Or and secondly, the gene therapy. So vis-a-vis gene therapy, how would you place the two?
Right, so both really very good questions. The long-term carcinogenicity with thalidomide, I mean, as I said, in the UK, we are unable to use these agents. We have to remember that the drug was originally approved as part of a anti-emetic regime. So the real important thing around the long-term carcinogenicity of drugs like thalidomide is going to be data that comes out of multiple myeloma and other clinical indications, whether there's new incidents of secondary malignancies. And in the myeloma cohort of patients where the drug has been used for a very, very long time, there have not been really much by way of reports of new secondary malignancies. The other thing is that the Indian and the Chinese studies, those patients have been exposed to thalidomide, most of them now for well in excess of 5 years. And we've not been hearing reports being published of malignancies. And I'm sure that my Indian colleagues will be the first to report if, God forbid, secondary malignancies came from thalidomide. So I'm fairly reassured by the clinical use experience so far with regards to the anti-angiogenesis agents. So I think that they are potential for exploration. This is the other reason why a long-term clinical trial, which is properly regulated by a pharmaceutical company with a repurposing label, is so important, because it will address all of those questions. The gene therapy, I think haploidentical transplant in sickle 100% is the way we need to go with the sickle patients. Anyone who's got a haploidentical match, we should definitely be looking at the Vanderbilt cohort regime and offering it to those patients. The gene therapy, I've had 4 of my patients cured with the Vertex product, 1 of them cured with the Bluebird Bio product. My young girl who was transplanted many years ago now is doing extremely well. So busulfan does have toxicity. We have to accept that. But there's always going to be a balance with any therapeutic intervention that you take. You have to accept what the risk versus the benefit and the impact on quality of life is. And with proper consent, if patients are in agreement with going through that, then absolutely we should offer it to them, because quality of life is a major issue for many patients. Even though we say that they should lead a normal life, thalassemia does affect their quality of life in many ways.
Thank you, ma'am. Dr. Ruchira Mishra, your question.
Thank you, Dr. Shah. That was an extremely interesting lecture. I had a few questions. Since we do a lot of transplants for thalassemia, one of my first questions to you was that you mentioned that you were using a reduced intensity conditioning regimen for your transplants. Now, what we found is that if we use reduced intensity regimens, we are getting a lot of graft failure. So what regimen are you using? And how do you avoid that graft failure was one. And what was that pre-transplant conditioning that you talked about, which helped to reduce graft failures, was the other question that I was interested in.
Yeah, so
and
that's
really... question was... Sorry. My third question was, since the world seems to be moving from busulfan to triosulfan, especially for thalassemia, have you looked at any studies that talk about using trio when you're looking at either gene therapy or lentiviral therapy for thalassemics?
Yeah, so I'll answer the last question first. So I was very keen on trio. It doesn't really work very well, so we can't use trio. The reduced intensity transplant conditioning regime, the data that I showed, it's worked really well in sickle cell patients with haploidentical transplant. It has not worked well. The thalassemia patients that were transplanted in that cohort did not get a good enough response. So the Vanderbilt group is now looking at doing further manipulations with the reduced intensity regime to see if they can get because the degree of ineffective erythropoiesis in thalassemia is so high, they will get graft failure if you're using a low intensity regime. So the low intensity regime that I've spoken about for haplo does not work in the thalassemia population. They tend to get relapse very early on with that. So the data for the haplo is sickle data that I presented. Joshua de la Fuente is working on reduced intensity regimes as part of one of his clinical trial projects. So hopefully he will inform us better.
Thank you, ma'am. Dr. Swati, ma'am? Yes, ma'am.
So that was a very good talk, and I really liked repurposing of the already available drugs like thalidomide. This question is to my other Indian colleagues. How many of y'all are actually using thalidomide, either with hydroxyurea, without hydroxyurea, with folic acid, without folic acid? How many of us are actually using it is a query. And
so
Yeah.
I know, ma'am, that Borivali was part of a trial for doing thalidomide with hydroxyurea, but we've had patients who come into us for transplants who failed thalidomide and hydroxyurea and that wheatgrass regimen, which another consultant is actually using and promoting. So we've seen quite a few failures rather than success stories so far.
And I also want to just put, like, this is not my personal experience, but I know of at least 2 patients who have been diagnosed with AML, who are thalassemia major and have gone to transplant centers for transplant. So the question about secondary malignancies following thalidomide is, I think, a very big question.
Yeah, no, I think that's a really important point. And again, I will very strongly recommend that for all of the projects that you do, that you really do that long-term follow-up, identify, and then publish, because without that, we don't know what the actual result is. And I have to say that the experience with these drugs is predominantly in India and China and Pakistan. And certainly in the Pakistani population, and I've seen a number of patients who've been on thalidomide, they've had very good responses and become transfusion independent. This is data from Dr. Ansari's group and people working in Peshawar as well. So they've had good responses. I think the genotype, this is again, why I go back to the point about having a properly regulated, properly set up clinical trial, because then you can look at the genotypes, assess which particular groups are going to be the people that are most likely to respond. And then, you can then sort of streamline the therapeutics that you're going to be using for particular groups rather than giving it as a blanket to everybody.
Thank you. Thanks so much.
Thank you, ma'am. Just another add-on. From what age group are you prescribing thalidomide and hydroxyurea in thalassemia patients?
I'm not using it at all. In the UK, we can't. So it's my Indian colleagues who have been using it. I think they've been using it in people over the age of 12. I think one of the Chinese studies was children over the age of 12. The other studies that are in the meta-analysis were over the age of 18.
And the dose was starting with the low dose of 50 milligrams.
Low dose. It's a very low dose of thalidomide, and a low dose of hydroxyurea if they're using it. So it's 500 milligrams of hydroxyurea.
So by what time period we will say that patient is not responding to thalidomide and hydroxyurea? If the patient has been
6 months. Yeah, almost everyone has responded within 6 months. If they're a responder, the response is very quick, from what I can see from the data that's been published. But again, remember, I have no experience with thalidomide because of where I live and the availability of the drug. But from the data from the clinical trials coming out of India and China, the response in almost all the patients who are going to respond was within 6 months. So I would give a 6-month trial, nothing lost, nothing gained, and then go from there. Right. I'm going to have to, Dr. Purana, just say thank you so much for inviting me, but I absolutely have to leave at 10 o'clock UAE, not UAE time, 10 o'clock
How much more
Saudi time.
How much more?
We're 10 o'clock.
It's 10 o'clock? Okay. Fine. So thank you so much, ma'am, for that fantastic talk and wonderful discussion, whatever time you have. Thank you so much, ma'am. Thanks a lot.
Thank you.
And
Thank
I
you
want
so
to
much
invite
for
all
inviting me.
participants as well as audience to participate in this webinar. Meet you next week, again Saturday, Sunday. Thank you. Thanks a lot.